We would ask that for best results, you choose one mode of audio, either through your computer speakers or the phone, but not both. We are encouraging your participation today. We have an hour. Our plan is to get through the slide presentation in the next 30 minutes. And from there, we want to open up the last 30 minutes for your questions. We will instruct you when you are able to ask a question. Okay, let's get started. So what are the reasons for the changes? Well, first of all, the two areas that are changing on the CANS application are consent and the accesses section in the diagnosis portion of the CANS. And the reasons for these changes, particularly with consent, is really in response to a long requested option that providers have told us from the beginning that they would like. We also recognize that by sharing CANS across providers who are caring for the same child and who have consent from each provider, that we're building the capacity for greater collaboration. So that is the main reasons for the changes to the CANS and consent. The second piece on the accesses is really due to recent changes to the DSM. So we needed to make accommodation for that. And also the changes to ICD. ICD is International Categorization of Diseases. And so in keeping with that, we're dropping accesses 1 and 2, and we're renaming the other ones. As we get into this presentation, you will see in the slides what those changes look like. Let's start with the new consent process. The new consent process permits a provider to enter the CANS in the virtual gateway and share the CANS across all other providers whom the caregiver has given consent. This approach supports CBHI's family-driven, community-based collaborative model of care. So how will this work? And this is an important slide for us to focus on, because I think it's a lot of where the questions may come from for folks who are getting ready and prepared for the change. So our code drop, as we call it, when the application changes, actually happens on a Sunday. I hope none of you are working on a Sunday, but you never know. So starting on Sunday, February 22nd, all prior consents will expire. So that basically means that the application will be reset so that you will need to obtain consent the next time you see the families. So this is an important part also. A lot of folks have already called us and contacted us about this part, and what you need to know is that you must obtain new consent from the caregiver before you enter a new or revised CANS for the child. So on February 22nd or the next day, you do not need to obtain consent for every family you're working with. You need to do it before the next time you enter a new CANS for the child. And it may work out conveniently in that case that it happens to be the next time you see the family. We want to also let you know that in the case where a family declines consent, the procedure for setting consent to no is unchanged. There's nothing different there. We also know that most people give consent. I believe that the consensus is about maybe 97%, if I have that correctly. It's somewhere near 97%. So for less than 3%, for folks who've had no, that remains unchanged. So how will this work? We'll continue with this this part of the presentation. The new consent form explains to the caregiver that by signing the form, they are given permission to a provider to enter the CANS on the VG, sending the information to UHS, and the MCEs paying for the service. and for the state to share the CANs on the VG with any other providers to whom the caregiver has given current consent. This does not represent a radical change to the current consent. What is different is that it allows you to share the consent with other providers who are caring for the same child who have permission. So what are the benefits of this new process? We see the benefits, and we hope you will too, with allowing providers caring for the same child to have a clear and current picture of what is happening in the child and family's life. It's important when a child is cared for by multiple providers or requires treatment in multiple levels of care. We think that this will make an important difference, that you will be able to see CANs that have been done for the same child that you're caring for. It helps to build collaboration and make sure that everybody's on the same page while saving time for providers and families. And when I get further along in this presentation, you'll hear a little bit more about how it saves time. An important part of this is that families will not have to repeat their whole story. It's something we've heard over the years that is particularly frustrating for families, and I'm sure it's something you hear with families when they feel they've already explained their family story and that they have to go through it again. Having access to information that fills you in on that will help focus and move the conversation further with the family. Another benefit that you'll find is that as a provider, you'll have immediate access to current information that affects the child's care. By being able to view, copy, and edit in existing CANs, you're saving time and effort. And in that regard, what you are going to be able to do is see previous CANs that were prepared for the child, be able to see what kind of ratings, what type of concerns and issues, needs and strengths have been identified, how they've been rated, and how other providers working with a child is clinically assessing the situation. In addition to that, you'll be able to view, copy, and edit an existing CAN, saving time and effort. That means that basically, if you copy a CAN that was done by another provider recently, you'll see the most recent CANs. You can go in, you can, when you're ready to enter the CANs, you can look at the ratings that they have. If you're in agreement with those ratings and you don't see anything changed, you can keep those ratings. You simply go in and edit the items in which you see change. And of course, we always encourage you to add your own comments in the text fields and the summary text fields at the end of each domain. So let's start with what's different about the new process. What's different is that the language is more user-friendly. We think that's going to be important for your understanding, but also for the families, that the families will have a better sense of what they're signing. So we think that the document is more useful in conversations about consent. What I would also like to say, just stepping back a little bit, is that I'm hoping that most of you have received and had an opportunity to read the newsletter. The newsletter contains an actual copy of the new consent form with the user-friendly language. So it gives you an opportunity in preparation for this change to see what this language looks like, become comfortable and familiar with the document. The documents are available. They're still available in 8 languages. That's what the current language capacity is, and we've made sure that they're all translated into 8 languages. The new consent also permits providers with active consent who care for the same child to have a clear and timely picture of what is happening in the child and family's life. That's probably the most important part of the difference, that you're going to have a timely picture of what is actually going on with the family, and that is hopefully going to help facilitate your conversations with the family as you prepare and use the CANS as part of your behavioral health assessment. And so how this will look is that when a new provider enters a CANS for the first time, that may be you, that you're going to be able to automatically see a list of the previous CANs completed by other providers with the current consent. So when other providers caring for the family who have completed CANs online have that record in the application system, you're going to be able to see it. You're going to be able to view it. You're going to be able to copy it. You're going to be able to edit it. So much is unchanged, actually, in the process, and let me go through some of those things. The fax process is the same. That is unchanged. The process for managing consent in the application is the same. The provider must still enter the SED section in the VG and complete the CANs on paper and enter the CANs into the child's medical record for those who say no to consent. So that's an important piece. If you have families who do not agree to consent, you must still complete the CANs on paper and enter the SED section on the VG. What's also unchanged is the expiration process. The CANs consent will expire after the time specified on the consent form. That time may be an agreement you have between yourself and the family. Say someone says, I'll give you consent for 6 months. I don't know if I'll be still doing this in a year, so I don't want to commit to a year. So they have that option that you can negotiate that it's for a specific period of time that's agreed upon between yourself and the family. But the default is the same, and that is a 12-month period. Now I'm going to go through with you the procedure of what happens when the caregiver gives consent. And the reason I'm doing this, I'm going to present these various options that are unchanged to put them and prepare you for a context of what happens when it is changed. So that's why I'm going through this information that I know a lot of you are already familiar with. And so as you know, the provider gives consent form to the caregiver or the legal guardian and explains the process. The provider can still print the forms in advance, and as a matter of fact, what we would encourage you to do is, since you all through the newsletter have access to the new form in preparation for the new release on the 22nd, feel free to make copies of those so you have them on hand. Do not start using them before the 22nd, but make sure that you have them available on hand for yourself. And so the other part that remains unchanged is that you can still click to find consent forms from within the application or from the website. More information about what is unchanged is that the person, the caregiver, giving permission for consent signs and dates the form. That now authorizes the provider to enter the CANs into the VG. The process of going on to the VG remains the same. The provider selects the Manage Consent tab, clicks the Manage Consent sub-tab beneath it, and then enters the member's Mass Health ID number. The provider selects the Yes button, then enters the relationship of the caregiver to the member. The relationship of the caregiver to the member is oftentimes it's a parent, but it could be other caregivers, and you might recall that there are drop downs with different categories from which you can select. At that point, the start date for the consent will default to the present day, and the end date will default to 1 year from the present day. But once again, the provider can choose other dates at the direction of the caregiver. The provider then clicks OK, and then OK again to print the pre-populated consent information sheet, which must be used as the fact sheet cover sheet. That's a little confusing. It should say consent fact sheet, but unfortunately it does not. And that's how the system is set up. So it says consent information sheet. And what's important about that is that if you use a fax cover sheet that is not the consent information sheet, it will not properly register that you have consent in the Mass Health system. We've had a lot of problems, not so much recently, but in the early days where folks used their organization fact sheet and not the one that comes from the application, and the consent was rejected. So we really like to stress the consent information sheet, which is the fact sheet, cover sheet, must be used. The other thing that's really important that we want people to know, and has over the years been a source of some confusion for some, is once you fax it in, you take it and you put it in the child's record. You do not mail it to the state. It becomes part of the child's medical record. So that's where that stays. The providers fax the CANS information sheet with the signed form together to Mass Health. The CANS information sheet is one sheet. The signed consent form, the new form, is 4 pages. So it's the cover sheet plus 4 for a total of 5. And the number remains unchanged. It's Mass Health at 617-887-8708. As we continue, you will see that the procedure when the caregiver declines consent is also unchanged. So if a family says no at the beginning or at any point, it remains unchanged. The provider logs into the VG, selects the Manage Consent tab, enters the Mass Health ID for the member, and then documents the caregiver declines consent. The provider also makes a note of this in the medical record. The provider does not fax or send any notice of declined consent to Mass Health. The next part that we'll talk about is when the caregiver cancels consent. Occasionally, at some point in time, a family might decide that they want to continue to work with you, but they've reconsidered and decided they want to cancel consent. So what we'll tell you is what is unchanged about that, again, is that the provider goes onto the CANS application on the VG and changes the status from yes to no. So that's an important piece. You must do this step. Then going forward, the system will only allow you to enter the SED demographic information for the member. You, from there, must enter this information on paper. You finalize the CANS as documented on paper. And then, again, you include it in the child's medical record. There is one procedural change for when a caregiver cancels consent. We ask that in the instance that you have someone who has said yes and then cancels it and now it's no, that you have to notify Mass Health of this, and you do that by creating a letter and having it signed by the caregiver. Then you can scan a copy of this letter and you send it to us through the mailbox, and the email address appears here. I'll read it for you. It's cans-cbi@massmail.state.ma.us. We'll leave this up for a moment so you'll have time to write it down. We expect this would be a very small percentage of occasions that this would occur, but there is this option in the case that a caregiver changes their mind. So what happens when a caregiver grants consent for multiple providers? That's what we've been talking about, the sharing of the cans across providers. Each provider obtains consent as usual. One provider's consent has no effect on whether other providers have consent. So you're individually obtaining consent. As before, the consent is for the whole organization, not for specific clients, not for specific clinicians, I'm sorry. If one clinician changes consent status for a child, it changes in the organization. You might remember that presently, when you get consent and you work within a provider organization, that others within your organization can see that CANS. If you change the consent status from yes to no, that changes it, obviously, for others in the organization. They cannot see it. From there, when consent is granted, providers will be able to view and copy CANS across provider organizations with active consent. So when each provider A gets consent, and then provider B gets consent and provider C, each one of them obtains it individually, but then by having it for the same child, they're able to look and see the CANS completed by other providers for the same child. So if you are provider A and you've completed a CANS and now the child is being seen provider B and provider B gets consent, you will be able to copy the CANS that provider A did. You can copy that CANS and it's yours to edit. Your edits have no effect on the CANS you copied, so you're not tampering in any way with provider A's CANS. You've made a copy of it. And that copy is yours to edit, so that when you review it, if you say there are 66 items, say you're in agreement with 43, that leaves you 23 where you are thinking that this, based on what you're seeing and hearing at this point in time, the ratings are different. So you would just go into those items and make changes. And again, we encourage you to add comments that reflect your thoughts on those changes. The other piece we ask people to pay attention to is when you copy a CANS, make sure that when you're entering the demographic information, it asks you for the level of care for the child. Well, if provider A is an outpatient and provider B is in-home therapy, provider B needs to make sure that they change the level of care to say in-home therapy. Otherwise, it will continue to say outpatient. So that's an important piece to remember. So what happens when the caregiver agrees to consent for provider A but not for provider B? Provider A would manage consent as yes, and Provider B would manage consent as no. Provider A will only see demographic and SED information collected by Provider B, since the system will not allow Provider B to enter the full CANs in the absence of consent. So Provider A's CANs are not visible to Provider B. We hope that that's clear for folks. We understand that that's the part that's the change. I also want to point out for you another dynamic where you may have three providers, Provider A, Provider B, Provider C. The family may agree for Provider A and B to have consent, but not Provider C. And so the same scenario would apply. A and B can share and copy. Provider C could not. So Provider C, in order to be engaged and involved with A and B, still has the option to print out a copy and make it available for A and B, to give it to the family, to bring it to A and B, or A and B could request a copy if the family agreed to that. So they are able, because the consent is basically allowing the information to be put on the application. The family may not mind if the information from Provider C is shared with A and B. They just don't want it shared through the application. So you can still print out copy and exchange CANs between providers otherwise, but this would just prevent you from entering it on the application. I hope that that's clear to folks, and that from reading the materials in the newsletter and the CANS FAQ, that this connects some dots for you and that it's clear. What I could say to you is that we'll have additional information available to help you with this. On February 22nd, we have how-to reference guides and online tutorials. They're found at the CANS website on the CANS page on the CBHI website. And these are basically written documents that have screenshots that will share with you again much of what I just said. The online tutorials are actually a guided tutorial that helps you see how to enter this information. It walks you through it step by step. If you go to the CANS page of the CBHI website, you'll find it at this email address, www.masshealth/CANS. When you get to that page, you will see various options. You can click on how to use the CANS application on the VG, and there you will find the reference guides. You'll also find the tutorials further down. In addition to that, CBHI developed a couple years ago now a CANS family guide. It's a 3-page printable document that can be found at this page that explains the what and the why of the CANs, including consent, and explains to families that CANS is changing effective February 22nd. So we always encourage providers to use the family guide, particularly when you first meet a family. It's a good way for them to have something that they can read at their leisure or with you. It's also a good way for you to help explain to families what the CANS is. So we would encourage you to use that, particularly as part of this process. We think it might give you some language and words that are helpful in your conversation with families about consent. So today's webinar is going to be recorded. It's going to be posted on the CANS Training and Certification page via the CBHI website. We're also going to get it up on the CBHI website too. So it takes us a couple of days technically to get this organized and posted. So by next week, you will be seeing. By next week, you will be seeing the CANS training page available. If you go again to the mass.gov//masshealth/CANS, you'll come to the web page and you'll see the link for training and certification. In addition to this, after you've taken the time to read all the materials and process this information, if you still have questions, you can always call the helpline. And the helpline basically will ask you to describe what your problem is. So to the extent that you can, please describe what part of the problem you are having trouble understanding. That will help make sure that the call gets properly triaged to the right place. Most calls will come directly to the CANS training program. We have a help desk coordinator who handles those calls, and additional staff will be available to also assist. The customer service number is 1-800-421-0938. We ask you to write that number down and keep it for future reference. That's the number you call for any help with CANS assistance. Also, for those who need assistance with hearing, they can call the TTY number. That would be 617-847-6578. So those are your information. Those are your information. Those are your information numbers and resources. I hope that most of you are familiar with it. You'll find this information also on the back of the newsletter. We always include that, and on the websites. And a really simple way to get to the CANS website, if you somehow forget to write down this email address, is just Google CANS, and it will bring you to mass.gov. In addition to the information about this, there is a lot of other information about CANS in general. Answers to most CANS questions beyond consent are also found at this spot. So we encourage you to use that on a regular basis for your questions. But of course, if you still have questions or need additional information, you can call customer service and the call will get to us. Okay, at this point, I'm going to turn over the webinar to Jack Simons, my colleague. He's going to walk you through the next part on diagnoses. So at this point, I'm turning it over to Jack.
Thanks, Deb. Good afternoon, everyone. Thanks for joining us. We want to go to your questions, but first wanted to make a brief comment about changes in the diagnostics section, which are really quite minor. Principally that we have dropped Axis 1 and Axis 2 that used to be part of DSM-4. And we've renamed the remaining fields, which we are retaining, and we've renamed the section. It's now called Diagnostic Factors, effective the go-live date, which at this point is February 22nd. The reasons for doing this really relate to simultaneous changes in the DSM and ICD, which sort of made it impractical for us to continue to capture the primary diagnoses. So nothing's being added. 2 fields are being taken away. It'll be in the next slide. So Axis 1 and 2 are going away. Axis 3 is renamed Physical Conditions, which is what it was all about before. Axis 4 is renamed Psychosocial Stressors, same as before. Axis 5 is pretty much the same thing. It's a global functional scale. There's a small change in that we're not using the GAF. We're referencing instead something called the Children's CGAS, Children's Generalized Assessment Scale, I think, which really is the same scale as the GAF, but it's sort of tuned for children and adolescents. And if you're not familiar with it, we can send you a reference of a paper that was published on it quite a while back. But also, if you go to the help text, it sends you to a link that gives you those anchors. It's not going to change the ratings on Axis 5, but the descriptions of the different levels are more appropriate for kids and adolescents than with the GAF. Next slide. So this is what it looks like now. It doesn't show Axis 1 and Axis 2, but if you're familiar with the application, you know that those used to be there. This is going, those will go away. These remaining fields will still be there, but they're going to be changed as you see in the next slide. Now the section's called Diagnostic Factors and Physical Conditions, same as before. Psychosocial Stressors, same as before with all those things that you can click on, gives you choices. And then the 0 to 100 scale, which is now CGAS instead of GAF. So not much of a change there. If you have questions, you should use the resources that Deb has directed you to. You've already seen this slide. Next slide, please. Okay, so that's all about diagnoses, and now we can take your questions. And Angie, people should type them in, is that right? And we'll see them. So we're still here, we're just waiting for people to populate our screen with their questions. Okay, so one question about consent. If a parent declines consent, how should it be documented? I think Deb discussed this. You manage consent to know in the application. You make a note in your record that they did not consent. You don't send us anything. How soon will the updated consent forms in all the language be available to download? Good question. Mass Health Publications has a policy that they don't post forms until the go live date. So we were not able to put them up. We are inquiring whether we can get these forms in all the languages in advance to mail out to you. So we'll have more information about that. Obviously, it would be good if you did have, say, a Spanish form in advance. But we couldn't post them on the web until 2/22. You should email a request to us for those forms if you want one of the other language forms. We can't say for sure if we'll be able to put our hands on them yet, but if we can, we'll send them out to anybody who needs one. And again, it makes a lot of sense to print those up in advance so you have them on your desk in the languages that you're likely to use. They're kind of jumping around, so it's hard. Okay, sorry, technical problem here. Is there a way to document consent or lack thereof for a specific category? Kimberly, I'm not clear what you mean by specific category, so if you amplify your question, we'll try to answer it. When is the Spanish version available? Again, those will be posted by Mass Health Publications on the Go Live date, which at this point is February 22nd. If we can obtain them earlier, we will make them available, but we can't post them until that date. How many languages can we get the Family Guide in? I don't know the answer. The Family Guide is in 8 languages?
I'm sorry, English and Spanish.
Sorry, English and Spanish for the Family Guide. We could certainly look at translating to other languages too. I think that would be partly in response to, how many inquiries we have. So let us know if you need the Family Guide in other languages, and we'll see what we can do. Okay, when a family signs the new consent form, will providers be able to see the cans that were entered prior to the new release? The answer is yes. Where will formal diagnoses go? Well, they won't go into the application anymore. That is what used to be Axis 1 and 2 back when we had a multi-axial diagnostic system, which was DSM-4. We're just not going to capture them anymore. It's not that we don't think they're important, but it was no longer really feasible for us to have those fields. Obviously, all the collaboration that Deb was talking about should include sharing diagnostic impressions, but we won't be doing that through the CANS fields anymore. Certainly appropriate for you to include diagnostic impressions in the text fields, however, and that will probably be helpful to other people who are looking at your CANS. What do diagnostic factors look like? Any examples to provide? So I think if you go back, when the slideshow is posted, you can go and see that it really doesn't look any different than now. The diagnostic factors are the psychosocial stressors, what used to be Axis 4, the physical conditions, what used to be Axis 3, and the overall assessment of functioning. That one. Can't quite see it. Once the first CANS is completed, an initial new CANS does not need to be completed. That's not a question, but I think what we need here is to confirm that the timing hasn't changed. So if you did a CANS in January, you won't have one due for another 3 months. So the next one will come due 90 days later, and then you'll do a new CANS with a new consent process. That hasn't changed. Okay. We did that. We did that. Here's one. We often find the fax number is busy for seemingly days on end. Is there a secondary fax number? So we had not heard this before. My impression is the fax has capacity to handle multiple calls, but we will check with the help desk about this. I don't know if there's been an issue that we were not aware of. Obviously, we don't want you standing for days by a fax machine, so we will look into that, and we are going to post answers to these questions online, so perhaps at that point we'll be able to answer this question better. How do we bill this through insurance company? So none of that has changed. Depending on what level of care you're in, different things are billable. If you're an outpatient, you can bill the assessment, same as before. And if you do that now, you have to be including the HA modifier with the assessment code in order to get paid. If you're in another level of care like ICC or IHT, you don't specifically bill for doing the CANS. It's just part of your billable activities, your documentation activities. So nothing about billing has changed under this system. Next question, if we utilize a data entry operator or DEO to enter the CANS, and we have one completed, say, on the February 14th, and the DEO goes to enter on 2/25, which is after the change to the application, will the old consent be valid on the 25th since the administration date was prior to 2/22? So all the consents will expire on the go live date, which is currently February 22nd. And it will be necessary if you go in to enter a CANS on or after the 22nd, that you will update the consent. You will manage consent to yes if you have the signed form. So I hope that's clear, but let us know if it's not. Are providers being encouraged to copy pre-existing cans, or is it simply that we have access to do so? So this is really a matter of clinical judgment. In general, I think it makes sense to copy pre-existing cans because it will save you time as long as most of the content is still accurate. And that's a matter of clinical judgment. So it's never okay to take a cans that somebody else created and just rubber stamp it and say, now this is my cans and I'm done. You really have to review the content and say, is this correct based on my current knowledge? And that's where you would make any edits that you need to make. Once you copy, it's your cans and you're responsible for the accuracy of the content. Another question. Some of our clinicians have already obtained the new consent. Will they need to obtain it again after 222? So if you have spoken with a family about the new consent form and that they have already signed it, that will be certainly good as of 222 or any date thereafter when you go in to manage consent. And it's fine to get the written consent before you actually have to go into the application. So I think that reflects good forethought, but you won't be able to change the consent. You won't be able to manage consent under the new system until the go-live date on 222. Some people worried that all consents would need to be managed on that date, and we want to really reassure you that that's not true. Unless you actually need to enter a CANS on that date because one is due, you don't need to go in and manage consent on the 22nd. Thank you, Deb. One other very important point, however, about switching from the old form to the new form. If you we need you to wait to fax the new form until the go-live date. So sit on them if you have them signed. Don't manage consent to the new form until the go-live date, and don't fax the new form until the go-live date. And the reason you can't fax in advance is our fax server at this point is expecting a 3-page consent for a 4-page total. We're going to have to tell the fax server, no, expect a 5-page total, 4-page consent plus a 1-page sheet that goes in the front. So if you fax the 5-page packet in advance of 222, it's going to confuse our robot and they will not be able to read it. So please don't fax the new consent form until the go-live date. A question about diagnosis. What types of physical conditions are considered for Access 3? Just medical conditions like diabetes, for example, or would an autism disorder or developmental cognitive disorder go there too? So I think those of us who use DSM-4, we're talking about using the same criteria, and basically those are physical conditions rather than developmental disorders, so I don't think you would enter autism or developmental cognitive disorders there. Okay, if provider A, B, C are in the same organization, are they all affected if a parent declines one? Great question. I think Deb did answer this, but it's certainly worth repeating that consent is still by organization. And what your organization has in terms of consent has no impact on what another organization has. So if a parent goes to a different organization and declines consent there, that does not affect the status of your consent. If a family is involved with Department of Children and Families, will the DCF worker be able to view the CANS that is entered from other providers? This is a great question. Again, the situation really has not changed, but this came up a lot at the very beginning, where people were concerned about if this health information is going to the government, does that mean other government agencies have access to it, like DCF or courts? And the answer is no. Only organizations to whom the family has given consent will be able to see the cans. It is true that DCF and DMH and DYS all use the cans, but their systems are separate. We don't have an ability to see one another's cans, and the new consent system is not going to change that. Do independently licensed clinicians need to sign the cans now that diagnoses are not included? So we actually had a discussion about this with the managed care entities. And I'm actually going to defer answering to this because I want to make sure I didn't remember the answer wrongly. We will post an answer to this question about whether an independently licensed person needs to actually sign the cans. Clearly, assessments in the medical record do need to be signed by independently licensed clinicians. That is comprehensive assessments. Okay. Can providers begin to have caregivers sign the new consent form prior to the 22nd and set them aside, and then enter consent after the 22nd? So I think we've addressed this, but let's hit it again. The answer is yes. And if you have a CANS due soon after the 22nd, it may make sense to do that. But you do have to set it aside, just as you have suggested. You cannot manage consent now prior to the 22nd for the new system, and also you can't fax them in until we have reset the fax system for the 22nd. Another question about DCF. If DCF has custody of a child, do we have to give them consent? So again, this is an area where really nothing has changed. In situations where someone other than the parent or caregiver has the legal right to the child's medical information or to medical decision making, then that person has the right to consent. And you would need to look at what your rules are and also what that person's legal status is. So if DCF has legal custody of the child, I believe it is the case that they would be the ones consenting. If I've misspoken on that, we'll post a correction, but I think that's the case. Just because DCF is involved with the child, of course, doesn't mean that they have control over medical decision making. Okay, is there a template for the letter once a family cancels their current consent, and will it be sent out by the state? So the answer at this point is no. You can just have write a letter saying, I, such and such person, decline consent for my child, have them date it, and fax it, scan it and email it to the address that Deb gave earlier. Sorry, I know we're jumping around in terms of topic. We're not really able to triage and sort the questions by topic, so we have to do it this way. Now that the CANS information, is being shared with other providers, can you speak to how parents' information is protected in the caregiver section, particularly substance abuse and mental health information, given that the CANS asks for the caregiver name? So again, this is an area where nothing has changed since the beginning, but of course this question has come up over time. And I think it's hard for us to tell you definitively what to do. You need to consult your own legal counsel and use your clinical judgment as to what you put in a medical record. Our attorneys have looked, our privacy attorneys have looked extensively at the consent form and feel it's appropriate from the state's point of view. If you decide that you need a more extensive protection, according to your own legal advice, you can always add an additional consent form for your purposes. You would not send that to us. You would still use our consent form for our purposes. And then you should always exercise some clinical judgment. Families should understand that they're not required to share all information, and that you don't need to put it all in the medical record. And I think we'd be happy to have more conversations with providers about that, but it's not a black and white question. I think there's a lot of gray that we'd be discussing with you. All right. If a new consent form is signed February 4th, will it expire February 22nd? Yes, it will. Yes, good question. Next question. SCD also has to be entered into the VG when a parent does not consent, correct? Correct. That also is unchanged. As Deb said, even when a parent does not consent, there is still a minimal amount of information. We usually refer to it as the demographic and SED that must be entered into the virtual gateway. So we're approaching 1 o'clock, which was the time that we had expected to do this webinar. We can continue a little longer until 1:15 for people who want to hang on. For those of you who need to go, we will be posting this, and we've provided a lot of information about where you can go with additional questions. Thanks for joining us. For those staying on, we're just going to keep going. When you say a consent covers an entire agency, is that true for multiple services within an agency, such as therapeutic mentoring, outpatient, and IHBS within an agency? So there's one little nuance here. When your organization enrolls with the virtual gateway, you actually have the option to set your different sites or services up as separate organizations. What we have seen is providers very, very rarely do that. So I think certainly for 99% of people on the phone, everybody within your organization is set up as being within one organization from the point of view of the virtual gateway. That means any provider, that is any clinician or DEO within your organization can see all the cans entered, whether they were entered by outpatient or inpatient if you have that service, or IHT or ICC. Now TM, of course, does not enter a CANS because they're not a hub service. They certainly may be consumers of the CANS. They should be receiving CANS from the hub. But so I hope I answered that within a provider agency, ordinarily everybody can see everything. Next question. Sorry, I'm having trouble parsing the question. When we document that someone has declined consent, do we document it on the consent form or just a regular note to file? So I think the answer is a regular note to the file. If you want to write it on the consent form and stick that in your record, you can certainly do that, but you do not fax in the consent form if a person has declined. You just go into the application and manage consent to know. Don't send it to us. Don't fax it to us, and please don't mail things to us through snail mail, because we don't have any way to deal with that. We still get things mailed to us sometimes. All right, on the CANS, is there a section about the caregivers asking about their own mental health needs? Would we be required to get, I can't see the rest of the question. Would we be required to get an additional consent, or would their information be covered in the existing consent? So our understanding is there's a single consent for the CANS, but again, this brings up that important issue about entering sensitive caregiver information into the child's CANS, and I think that's an area where you need to exercise judgment, where we really expect that you will have informed consent if you enter information, that caregivers should understand where their information is going and that they have a right not to share that information. Next question, if you're seeing a client for outpatient therapy, they also have IHT services and IHT, did the CANS, do you have, and you have no changes to it, then you do do you do 1, 2, or not? So yes, there is this redundancy that you have to enter it 90 days in each service. So the IHT provider, the ICC provider, and the outpatient provider, all within the same agency, or different agencies, still must enter their own cans every 90 days. However, under the new consent arrangement, if the situation is the same clinically, you really can save yourself a lot of time by copying a cans that was done by somebody else, confirming that the information is still correct, and then just finalizing it. Is there a way to specify consent for current and future cans, but not past cans? No, there's not. So when the new consent system goes into effect on the 22nd, it will also apply to cans that were entered in the past. Monica, great question. Again, it's about DCF, and it is DCF considered a provider? Can a caretaker refuse consent for a specific question? So really this is two questions. The first is again about DCF, and no, they are not currently providers. At the moment, the only providers using the system are mass health providers. It is conceivable that at some point in the future we would talk with you all about families having the option to make DCF a provider with consent, but currently that is not an option. And it would never be the case that a family's information would be sent to DCF without their consent. The same is certainly true of other state agencies. So the second part of that is, can a caretaker refuse consent for a specific question? And we certainly weighed that at the time that we were figuring out how to do the new consent situation, but it sort of raised an infinite number of contingencies that you could consent to this provider for that bit of information, and we simply felt it was too complicated. So basically, consent is for the whole cans. They can say no, even if one little piece of it, you know, is anathema to them sharing and they don't want to do it, then they should say no. If they say yes, it is consent for the whole document. All right, another diagnosis question. If diagnosis is no longer included in the cans, can a BA level ICC staff resume doing the cans if no other diagnosis is available? So my understanding is BA level care coordinators are allowed to be certified assessors and can enter information into the virtual gateway. If I'm wrong about that, we will post a correction. But in terms of who needs to sign off on which documents, still the comprehensive assessment, my understanding is that will need to be signed off by licensed clinician, and we're going to post an answer about whether the CANS document in the medical record needs to be signed off by a licensed clinician. I'm going to get information from the MCEs about that. All right, really that's the same question about, does a licensed clinician need to be signing off on the CANS? And I think we'll just post a clarification to that. What happens if a new CAN is submitted on the gateway without consent because not aware needed? What happens? So I'm going to guess what that question was. I'm not entirely sure, but I do think it's important for us to say it does happen from time to time that people enter CANs and then they call us up and they say, I didn't mean to enter that. That was a mistake. We do not have a way to remove CANs that have been finalized. So if you enter it because it's a sibling and you put in the wrong Mass Health ID, then you have entered wrong personal health information, and that's unfortunate, but we're not able to undo that mistake. Furthermore, and this does come up from time to time, if you have a clinician who previously worked for a different agency and now comes to work for your agency, and their access through the old agency has not been shut off through the VG, and they go and enter your members' information into their old agency, that is a serious breach. You are allowing your member information to be entered into another agency's medical record. So we really need to underline that part of your procedure when somebody leaves your employ, just like you get keys back, and you have them go through a sort of a debriefing procedure, you must contact the VG and make sure that their access to your medical records through the VG has been shut off. Similarly, when you have a clinician working for you who's maybe working for another organization, you need to be very certain that when they enter information for you, they are entering it through their access to you under the VG. Okay, so we have just a few minutes left to answer remaining questions. We'll do the best we can. How will we inform insurance companies of the diagnosis if they were previously relying on the CANs? My understanding is that you submit the diagnosis on every claim, and that you include the diagnosis with your comprehensive assessment. I don't think that payers rely on the CANs in order to obtain the diagnosis. If that is wrong, I'm sure we'll hear about it. But I don't think this is going to affect your billing in any way. If it turns out that there's more information we need to post, we will. Okay, many of these questions we have answered. Let's see if we can find one that's really new. Okay. Sorry. So Aaron, your question, if a member is receiving 3 services from the same organization, can we copy outpatient for IHT? Yes. Just be very careful. When you copy, it's going to put your name on it as the certified assessor. It's going to put the current date as the date of assessment, but it will not know what level of care you're in. So if your ICC entered the CANs that you're copying, but you are an outpatient provider, you need to be very careful to change the level of care to outpatient. Otherwise, everybody's going to think that you were entering a CANs for the other level of care. Can we bill CANs once a year? I assume that is a question about how often you can bill the assessment code if you're an outpatient. And that is really a question that I think you need to direct to your managed care entity as to how often they allow you to bill the assessment code. I'm sorry, I don't have an off-the-cuff answer to that. What's the time frame to get the CANs done after seeing the client? Again, that's really an MCE question. I don't think the state has created a time frame for that. What I feel confident saying is it hasn't changed with the new release of the the new consent process. So whatever rule you were following before, in terms of time frames, that would still be correct. Okay, another excellent question about copying. If a provider copies a CANs from another provider and there's information in there that originated in the first provider, will the CAN show what was written by whom? So, no, we did not design it in such a way that it stamps prior information with the name of the person who entered it. So you need to be thoughtful when you go through there. You can remove comments. It will timestamp and date stamp comments. You've probably seen that. That's not new. But it doesn't say who entered it. So you really are responsible for all the information. If there's information in there that you believe to be wrong, then you either need to say this was entered by a prior provider and is not correct, or more likely you would simply remove the comment that was erroneous and put in your own comment. Okay. When copying and editing, are you only using cans that have been completed within the past 30 days? If you use another provider's cans, we should make sure that it's clear it was information from the last 30 days, correct? Actually, you can view and copy beyond the last 30 days. When you do the cans, obviously you're expected to be thinking of the last 30 days as the time frame, but the copy process does not limit you to the last 30 days. Okay, this is a copy about faxing. When the cover sheet is generated, we've noticed that it puts the date that the sheet was generated on it. Does it have to be faxed on the date that is on the cover sheet? The date that is on the cover sheet will be the date that we believe it was entered. So the fax server at our end is able to read those fields off the cover sheet, which is why you need to use the cover sheet, and it will enter that date as the date of the consent. Okay, I think we have time for probably one more. Again, a 42 CFR question, which relates to, among other things, substance abuse information and the federal rules about information. Does 42 CFR Part 2 apply to the new availability to copy and redisclose substance abuse information? To the best of my knowledge, nothing has changed with this. The same conditions that existed before, that information was being shared with the state. The only thing is now information is being shared potentially with a broader community of individuals to whom the member has provided consent. But I think the same guidelines probably apply in terms of your thinking about which information is appropriate to enter, and also making sure that the person who has the right to consent knows what's being entered and is making truly informed consent about whether that information should be shared. So I'm getting hand signals. That means we need to wrap up. So I'm going to transfer this back to Deb. Thanks all for participating. I know there'll be more questions. We'll do our best to answer them going forward.
Yes, thank you all for your interest and participation. I would just like to say that in looking at many of the questions we're getting, they're questions that remain unchanged. The answers are unchanged, and the answers to those questions can be found on the CANS page of the CBHI website. The quick way to get there is just to Google CANS, and you'll see mass.gov, and then you'll see that there are, if you scroll down to the CANS section, it will open up and you'll see FAQs, you'll see answers to many of these questions that are here. For those who have questions related to consent and diagnosis, we're going to, as we said, post this information. We're going to follow up on the questions that we didn't have time to answer. So folks should expect by Wednesday that if they go to the CANS website and they look at the training and certification link, they'll open up to the CANS training page. On the right-hand side, there's a link to post-certification resources and information. You'll find the web page there, the webinar there. It may take another couple of days to get it on the CBHI site, which is the general page for CANS, for CBHI. We're going to post it there too. But basically, by Wednesday, you can go to the CANS training page. And again, you can call the help desk. We'll follow up with those who have CANS and consent questions that have been not publicly answered at this point. And we thank you and appreciate your time. I have to say, I can't encourage you enough to go to the CANS newsletter that you receive in your weekly notice. Anybody that's a CANS certified assessor gets an weekly email on Monday at noon that explains the changes and has a link to the CANS FAQ and the family guide. It also has a newsletter. In the newsletter, you'll find a link to the consent form. It also has links to things like the CGAS. Somebody asked that question. If you read the newsletter, you'll see a link and you can print out the CGAS. Your other option is to Google CGAS. You'll get it there too. Okay, again, thank you all for your time. We appreciate your interest, and good luck. Thank you.